Dear participants, in this lecture, I am going to discuss about the anatomy of mandible and associated structures. Well, mandible is the largest and the strongest bone of the face, consisting of a curved horizontal portion, that is body, and two perpendicular portions, the rami. The buccal cortical plates of the adult mandible is often significantly dense so as to preclude any effective infiltration anesthesia in the vicinity. The external or lateral surface is marked in the midline by a faint ridge. It is an indication of the symphysis of the two pieces of the bone from which the mandible is created. In the region of the second premolar on each side, midway between the upper and lower borders of body, lies mental foramen, through which mental branch of inferior alveolar nerve exit. The lateral surface of each ramus is flat, composed of dense cortical bone, and it provides attachment for the masseter muscle. The superior border of ramus has two processes, the coronoid anteriorly and condyle posteriorly, and in between these two processes lies a sigmoid notch. The lingual surface of the body of mandible is concave from side to side, and mylohyoid line is present onto the surface that runs downward anteriorly, and it gives rise to the mylohyoid muscle. At the lower end of the mandibular foramen, the mylohyoid groove begins, and that courses obliquely downward anteriorly, carrying mylohyoid nerve and vessel. The mandibular foramen, it is located roughly halfway between the superior and inferior border of the ramus of mandible on the lingual surface, and roughly 2/3 to 3/4 from the anterior border towards posterior. The mandibular canal, that is the entry point of the inferior alveolar nerve and vessel, extend obliquely downward and anteriorly within the ramus, whereas within the body it courses horizontally forward, distributing small dental branches to the mandibular teeth posterior to the mental foramen. A prominent ridge that is known as lingula lies on the anterior margin of the mandibular foramen, and it serves as an attachment for the sphenomandibular ligament. When cut horizontally at the level of mandibular foramen, the ramus of mandible can be seen to be thicker in the anterior region than the posterior. There are two pairs of geniotubercles present in the midline on the lingual surface, superior geniotubercle and inferior geniotubercle. Superior geniotubercle give origin to the genioglossus muscle, whereas inferior geniotubercle give origin to the genohyoid muscles. The ramus of mandible has got two surfaces, lateral and medial surface, and this ramus is sandwiched between the two strong muscles, the masseter on the lateral side and medial pterygoid on the medial side. Ramus has got four borders, superior, inferior, anterior and posterior border. The two processes, that is the condyle and coronoid processes, are present at the superior border of the ramus. The condyle is a strong upward projection from the posterior superior part of the ramus, and at the neck of condyle lies the pterygoid fovea, to which lateral pterygoid muscle is attached. Whereas coronoid process is a flattened triangular upward projection from antero-superior part of the ramus, to which temporalis muscle is attached. This is the medial or the internal surface of the mandible or lateral external surface of mandible with the various muscle attachments. The lateral pterygoid muscle is attached to the pterygoid fovea at the neck of the condyle. The temporalis muscle is attached to the coronoid process. Medial pterygoid muscle is attached onto the medial side of the ramus of mandible near an angle, whereas masseter muscle is attached to the lateral surface of the ramus of mandible. Mylohyoid muscle is attached along the mylohyoid line on the internal surface of the body of mandible. Genioglossus muscle takes origin from the superior geniotubercle, whereas genohyoid muscle takes origin from the inferior geniotubercle. Digastric muscle is attached on either side near the lower border, near the symphysis of the mandible, whereas mentalis muscle is attached onto the lateral cortex near the lateral incisors or central incisor region. Buccellator muscle is attached to the alveolar process near the mandibular molar area. Coming on to the applied aspect, the density of the buccal and lingual alveolar bone is very high in the posterior area than in anterior area. we can say that anterior region, buccal and lingual alveolar bone is relatively porous, and that is why infiltration anesthesia may be successful in anterior region in certain individual, especially in pediatric population. With the passage of time, when mandible becomes edentulous, resorption of alveolar bone takes place, and this brings the mental foramina close to the alveolar crest. The mandible sulcus is a funnel-shaped depression on the internal surface of the ramus, and that houses the mandibular foramen. The importance of this particular sulcus or structure is that this is the particular area where ideally inferior alveolar nerve block solution should be deposited, because it directs the flow of local anesthetic solution towards the mandibular foramen. Lingual foramina are present in certain individuals in the molar region, and they carry sensory fibers from the mylohyoid nerve. Those innervate mandibular molars. There are certain cases wherein the classical inferior alveolar nerve block failed to achieve proper anesthesia of the mandibular molar. These are the certain cases wherein molars may get sensory supply, additional sensory supply from mylohyoid nerve also. So in those cases, inferior alveolar nerve block should be given at a relatively higher level before the origin of the mylohyoid nerve from the inferior nerve. The thickness of the soft tissue between the needle peritation and the osseous tissues of the ramus at the level of mandibular foramen average from 20 to 25 millimeters, and that is the depth of penetration while giving inferior alveolar nerve block. Bone contact is always a must while giving this particular nerve block, as if a person is not having a bone contact while giving this particular nerve block, the needle might go far posteriorly within the substance of parotid, and if the solution is deposited within the substance of parotid, it might lead to transient facial nerve palsy rather than inferior alveolar nerve block. Additionally, onto the medial side of the deposition site lies the medial pterygoid muscle. Actually, this is the space which is known as pterygomandibular space, that is in between the ramus and medial pterygoid muscle. While giving this nerve block, needle might penetrate through the medial pterygoid muscle, and this will result in post-op trismus in certain individuals. The height of mandibular foramen varies greatly, ranging from 1 to 19 mm or more above the level of occlusal plane. That is why coronoid notch is a more reliable landmark for determining height of needle penetration while giving inferior alveolar nerve block. The coronoid notch is lying along the anterior border of ramus, and that is the deepest point along the anterior border of ramus of mandible. This point has to be palpated while giving the inferior alveolar nerve block from the opposite hand, and midpoint of thumbnail directs the level of needle penetration, and that corresponds to the level of the mandibular foramen. The classical inferior alveolar nerve block bone contact area and Gauge technique bone contact area by needle are different. In classical inferior alveolar nerve block technique, needle contact is made in the region of the mandibular sulcus. At this point, the nerve is anesthetized would be inferior alveolar nerve and its different branches like mental and incisive, and also the lingual nerve that lies in close proximity with the inferior alveolar nerve. Whereas the area of contact by needle while giving Gauge technique of the anesthesia, it is the pterygoid fovea that is near the neck of the condyle, and since it is given at a slightly higher level, so nerve anesthetized are all sensory branches from the anterior and the posterior division of the mandibular nerve. These are the references for this particular lecture. Thank you so much.